Stream.
Yes.
Hi.
I hear you.
Okay, good. That we were having some technical difficulties, guys.
Oh, we're live already?
We're live. We're live. I don't know why it wasn't working, but we're good now. So, hi everyone. We're super happy you're here. Just a couple of housekeeping things before we get started. And say hi in the comments so we can see you guys. I really like to see where everybody's from and everything and kind of get an idea. So this is our second interview with Dr. Del Rivero of the NIH Center for Cancer Research. A few things before we start. The information presented today is for educational purposes and is not meant to be taken as medical advice for your situation. Please see your medical provider for advice specific to your situation. And if you need to see an expert on ACC, you can also reach out to Dr. Del Rivero. I am going to put up her email address if you need it. If you have any questions, definitely check out some of the Facebook groups on Facebook, obviously, and they can usually point you to an expert near you. So, also, if you could subscribe to my YouTube channel, it should be below, and you can check out my link tree, also linked in the description, if you have any questions about what I do and what ACC can do. So, I think that's pretty much it for that. Our guest today is Dr. Jadira Del Rivero of the NIH National Cancer Institute. And she is going to, her research focuses on neuroendocrine neoplasm and adrenal cortical cancer. We're kind of talking about adrenal cortical cancer today. So I guess we'll start with some questions that we have gathered from ACC patients and family. And if we have some time, we'll try to answer other questions in between or after. But we will also talk about Dr. Del Rivero's research and her work towards the end. So stay tuned for that. Okay. Ooh, looks like a whole bunch of people are. Oh, hello from Long Island. Very cool. Very cool. So our first question today is, what is the difference between secreting ACC and non-secreting ACC?
Thank you, Amanda. And thank you for having me again tonight. I'm sorry about the technical difficulties earlier today, but I'm happy to be with you, all of you tonight, and answer any questions you may have. So thank you so much for coming and listening to us. And we're here for you. So the first question is, what is the difference between secreting ACC and not secreting ACC? So I was just going to say what is secreting and not secreting, and then I'm going to give an explanation because I think it's important that we can explain exactly what that means. So secreting ACC is the adrenocortical carcinoma is producing hormone. That's what secreting means, the production of hormones. Non-secreting ACC is doesn't produce any hormone. Now, let's just go back a little bit about what adrenocortical cancer is. So adrenocortical cancer is when cancer cells form in the adrenal gland. So where are the adrenal glands? They're very tiny organs that is located sitting on top of the kidneys. The adrenal gland has two components. If we were to cut the adrenal gland in half, we have two components. The outer layer of the adrenal gland is called the adrenal cortex, and the inner layer of the adrenal gland is called adrenal medulla. The adrenal cortex produces three different types of hormones. The hormones that they produce is aldosterone, and aldosterone helps us regulate the sodium and potassium in the body, so it also helps regulate the blood pressure as well. cortisol. What is cortisol? Cortisol is a stress hormone. This stress hormone is also responsible for the fight and flight response. And the other hormone that the adrenal cortex produce is androgens. And what is androgens? They're also sex hormones. Those are the one responsible for the sex characteristics, the hair in the body, and all that. So I think it's important to know, because approximately 40 to 60% of adult ACC may produce hormone. And the most common hormone that is produced is cortisol. The second one is androgens, or sex hormones. So usually the presence of excess of cortisol, the way we recognize that is because they are very characteristic appearance, this excess of cortisol. The patient may have moon faces or round face. They can also have a little bit of fat in the back of the neck. They can also have increased weight. Another clinical characteristic is that they can have like what we call a purple stria. So they're a stria, but it's color more very dark, almost color purple. Also muscle weakness too, high blood pressure. It can also affect the bones and cause osteoporosis, decreased wound healing. So all of that is because of the excess of cortisol. Now, when there is an excess of sex hormones, the clinical findings of the excess of sex hormones is, for example, increase in hair in the face and in other areas that we don't want the hair to grow. Also in women, we have irregular menses. Also, the boys can get a little more deep. Baldness as well is one of the characteristics of excess of androgens, of testosterone. In this sense would be testosterone.
Okay.
So very rarely adrenocortical cancer may secrete other hormones like estrogen, or maybe the other one that we discussed earlier, like aldosterone. But I think but it's very important to recognize when adrenocortical cancer is secreting, because we can see the clinical findings, and also we can add medications that help us block some of these hormones as well. I think and usually whenever we have a patient with adrenocortical cancer that has these clinical characteristics, that's what it lead us to do more imaging studies like a CT scan and so forth. The non-secreting, I think we discussed, are the ones that do not secrete any hormones. Usually those tumors, they tend to grow. And actually, when the patient has abdominal pain, because of the increase in the size of the tumor, that's what it then leads to having a CT scan. But in those occasions, sometimes in the non-secreting ACC, sometimes they're very big because they tend to grow. And sometimes they can be in other places because they don't have any symptoms related to the hormones. So we say that the secretin produces hormones, and because of that, there are specific symptoms, where the non-secretin doesn't produce any hormones. And sometimes we don't know, we don't know what's going on. And sometimes we have this pain, we have a CT scans, or we have a little bit of shortness of breath, and that's what it led to do further imaging studies.
That makes sense. I actually have a follow-up question for that. How common are non-secreting tumors? Are they like more rare? Are they more common? I'm just curious.
Yes. So the non-secreting, the secreting or the non-secreting, how common is a non-secreting? 40%.
40%.
40%. So
Okay.
40 to 60% are the secreted hormones in adults. So just
In adults,
clarify,
right.
in adults, and about 40% are non-secreted. Now in pediatric ACC is a different.
Oh,
So
okay.
pediatric ACC, approximately 80 to 90% of pediatric ACC produces hormone.
Oh.
Less 10% or so are not secreted, but majority of pediatric ACC produces excess of hormone. And also, the most common hormones that we see in the pediatric ACC is testosterone, is the androgens, is sex hormones. Sometimes in a pediatric ACC, the clinical findings is that they have what we call precocious puberty, and that's one of the clinical manifestations of having this excess of testosterone or androgens. So it's a difference between pediatric and adult ACC.
Okay, interesting. So kind of going back to the hormones and the type of hormones, could cortisol producing ACC have an effect on executive function? Because, like you mentioned, the fight or flight response and just things like that. It's kind of known stress hormones we know can affect us. So we were wondering, like, how does that work?
Yeah, that's a good question, and so first let's just describe what executive function is. It's ability to do day-to-day activities, ability to think, the ability to focus, the ability to handle emotions. That's basically what the executive function is. But yes, excess of cortisol can have an effect on cognition and cognitive function. So that's we know, and because of that, that can also have an effect on the executive functions too. It can make somebody feel very fatigued and depressed, and I think it's important. So the answer to the question is a yes. The excess of cortisol can definitely have these changes in cognition, memory. And I think it's important to discuss that with your physician just to understand if what is this is happening, and that way you can have a full evaluation to understand if this is happening. I know that this is a question from a patient, but I feel like yes, this is something that it is there is a relationship, and the excess of cortisol can lead to the decreased executive function.
Makes sense. Okay. So our next question is, can you elaborate on Ki-67 levels and Weiss score and their implications?
Yeah. This is a great question, and I think it's important to make a clarification on what is the difference between Ki-67 and the Y score. So Ki-67 is a proliferation index of how the cells are able to divide under the microscope. That's the Ki-67. It's a number that they give us on how the cells are able to divide under the microscope. Based on the Ki-67, we can say whether an ACC is low grade, intermediate grade, or high grade. Low grade adrenocortical cancer, the Ki-67 is less than 10%. Intermediate grade is anywhere from 10 to 19%. And then higher grade is greater than 20% of the Ki-67. And I think it's important to know the number because it can also help us understand as well what will be the risk of recurrence as well. The higher the Ki-67, the greater the risk of recurrence, but also you have to keep other characteristics in mind, like the size of the tumor. Now, the Y score is different. The Y score is a series of 9 different items that looks at the architecture of the adrenocortical cancer, that looks if there is invasion. So there is 9 different things that is look under the microscope, that the pathologist is telling us about the characteristics, again, with the architecture, how they look in terms of the cells, the morphology, if there is an invasion as well, vascular invasion. So in each of one of those items, is a number. So the Y score, if the Y score is between 0 and 2, that means that the adrenal mass is benign. If it's anywhere or greater than 3, that means that there is most likely to be malignant. So the Ki-67, just to kind of like summarize, the Ki-67, it tells me what is the proliferation index, how the cells are able to divide under the microscope, and it also tells me whether the adrenocortical cancer is low grade, intermediate grade, or high grade. The Y score is telling me if the adrenal mass is benign versus malignant.
Okay, that makes sense. So just to make sure I kind of understand, for the Ki-67, that's kind of like how fast it grows in a way. Is that
Under
kind of
the microscope,
under the microscope, like
the
how
cells are
fast
able to divide.
Okay,
Yeah.
that makes sense. Okay, cool. All right. So our next question is, how common is hypothyroidism as a side effect of mitotine, and how is it usually treated?
Yeah, that's also, I think, the questions that are from the audience are very, very good questions. And as we say earlier, this is for education purpose. And if there is any specific questions that you would like to ask, just please feel free to email me anytime. But yes, I think it's important to understand a little bit more about the different side effects related to mitotane. So hypothyroidism is one of them. And the usually when and what is mean hypothyroidism, that the body doesn't have enough thyroid hormones in order to help with the function of the body. So whenever somebody doesn't have enough thyroid hormone, what happen is that there are changes in the body. You start gaining weight, you start losing hair, your skin is dry, uh, you have muscle pain, constipations. So there is different signs and symptoms associated with low thyroid. And patients that are on mitotine, they can also have hypothyroidism. Usually happened within the first year of starting mitotane. Less often, after the first year. Usually in the first year will be anywhere from 40 to 60% of patients having some thyroid dysfunction, and that's why it's important that whenever you're on mitotane to check thyroid functions. But yes, is the side effects of mitotane that we need to be aware. We need to check on having a blood test, and then we need to replete that currently. So how we treat it. So there is a thyroid hormone replacement. The name of the medication is levothyroxine or Synthroid, and that's what we given in those patients with low thyroid function or hypothyroidism. I think it's important also to recognize that. But also, if it is okay with you, Amanda, I would like to also mention some of the side effects related to mitotane too, because
Absolutely.
I think it's important to recognize and at the same time what we can do in those situations. One of the other side effects, it can affect the central nervous system. So that can present having confusion, some imbalance, fatigue, forgetfulness. So that can also be when it affecting the central nervous system. We discuss about the thyroid. It can also cause nausea and vomiting as well. That's one of the most common side effects of the mitotane. Usually, when that happened, what we recommend is to give an anti-nausea medication just to take it 30 to 60 minutes before the mitotane, and also can cause diarrhea as well. And if that happens, we can give some to control the diarrhea, like loperamide. So that's kind of like something that we do in those patients that that has diarrhea as a side effect of mitotane. Other side effects, it can also cause an increase in the liver enzyme. So we do check the lab. We check for that as well when we do blood work. It can also cause adrenal insufficiency. That's also a very important one. So, because what mitotane does, it is suppress any function from the adrenal gland, and more importantly, cortisol. So, and because of that, we need to replete. When a patient is in mitotane, we need to give hydrocortisone. Usually the dose of hydrocortisone, we need to give a higher dose of hydrocortisone, so the total dose is based on your height and weight. However, in patients with mitotane, we like to give higher doses, and the reason why is because mitotane accelerate the metabolism of hydrocortisone. So, and also we make changes also based on how the patient feel, because as we discussed earlier, fatigue is one of them. So I think we need to make adjustments based on the thyroid hormone based on the symptoms. Moreover, adrenal insufficiency by itself can also make somebody feels very fatigued. So, and that's we need to kind of like discuss with our physicians and make necessary adjustments in terms of the hydrocortisone and adrenal insufficiency. Other side effects sometimes is rash too, very rarely, but it can happen. So I think it's important to recognize all of the side effects and discuss with your doctor anytime that you are taking mitotane. Just discuss with your doctor and tell them what you're experiencing, so that way we can help you to minimize some of the side effects.
Right, exactly. Yeah, definitely. Because I know my mom's had a lot of interesting side effects from everything. So it's definitely been helpful to speak with her doctors to figure out solutions to dealing with those. So
Can I answer a question? I'm just looking at the
yeah,
chat right now.
absolutely.
It's okay that I answer a
Of
question.
course.
So and I think it's important because one of the questions is if you're unable to reach therapeutic level,
Hmm.
does that work? Mitotine work? And I think it's an important question. Sorry, because um, what we know is that mitotine, we in terms of the level, so we check whenever somebody's on mitotine, we check the mitotine levels every month or so, and the goal of what is described is 14 to 20. So that's usually what the books describe, that it has to be 14 to 20. And I have to say that a lot of doctors, they're trying to increase more and more and more until they can get that level. And what happened, the more you increase, the more you have experienced some of the side effects that we discussed. So the way me and maybe other ACC experts do is that we start dosing the mitotine. We start low dose, 500 milligrams twice a day, and then we increase by one pill. And we increase it until the patient is able to tolerate. Once he starts experiencing a lot of side effects, then we leave it there, and then we can keep monitoring the mitotine. I would tell you something that always I learned from Dr. Fojo as well, that having some levels of mitotine is better than not having levels at all. So if I see somebody that is 5, that is 6, I think it's okay. I understand that the concern is like, oh, maybe it's not doing it any good, but at the same time, we don't have any data that 20 is better than 15, or 15 is better than 10, or 10 is better than 5. The reality is that we don't have that data to tell me. But that being said, it's important to continue taking mitotine. Why? Because mitotine has two functions. It can also decrease the excess of hormones, and it also has some anti-tumor effect too. It may slow down the growth of the tumor. So those are the things that we know about mitotine.
Yeah, definitely important to know, for sure.
And just one comment. I'm so sorry. Mitotine.
No, you were good. You were good.
I mean, it can increase the liver enzymes. It doesn't mean that it damages. You can increase the liver enzymes, cause a little bit of inflammation. So in those situations, we just decrease the dose, we hold it, and then we just monitor. Okay.
Okay. No, that was good. Good to catch. Okay, so let me make sure. So actually, kind of going back to the side effects of mitotane, what is the effect of mitotane in the central nervous system? Is there any neurological deficit after I stop taking mitotane?
Yeah, I think as we discussed earlier, and as I mentioned, one of the side effects of mitotane, it can affect the central nervous system. How do we know? Because patients start to experience, forgetfulness, fatigue, um, involuntary movements as well, severe somnolence. They feel very, very tired. They don't remember things. And those are the things that are related to as one of the side effects affecting the central nervous system. Sometimes it can also be confused as the patient is having a stroke. So and they go to the emergency room, or they go to the doctor, and what happened is like they may not be familiar with mitotane, but that's important to keep in mind too, because it can sometimes feel like it looks like a patient is having a stroke. So in those situations, when that happens, is usually because mitotane level is greater than 20. So instead of, because anything that is greater than 20, we started seeing more side effects, and mainly affecting the central nervous system. So if that happened, usually what we do is we check the level, and then we stop mitotane, and we usually don't restart until maybe even a couple of months later. And then sometimes we decrease the dose as well of mitotane. But yes, I think it's important, if you have severe, increased severity of the symptoms, to talk to your doctor, check a level, so that way we know that the levels are less than 20, and just follow accordingly.
Okay, that makes sense. Okay, so our next question, and this is related, I guess, to the cortisol levels. What is adrenal crisis, and how is it prevented and treated?
Yeah, that's also a great question. Thank you so much for bringing that question as well. I think one of the things that I don't know if you mentioned earlier, Amanda, that I am, besides an oncologist, I'm also board certified in endocrinology. But my endocrine focus is mainly on the hormones secreted by the tumors. And adrenal crisis is something that we need to prevent in someone who is taking mitotine. We discussed earlier that mitotine decrease the function of the adrenal hormones. Mitotine, we call it, is an adrenalytic because decrease the function of the different hormones in the adrenal gland. Uh, and we discussed about cortisol.
Mhm.
So and cortisol is a very important hormone for us because it's a stress hormone. So whenever we have a surgery or we are under a lot of stress and infection, so the cortisol, it starts to be secreted to help us with the stress. It's a very very important hormone. Um, and in patient and patients that have, as we discussed adrenal insufficiency, we discussed earlier about the replacement. We need to make sure that the patient is on either hydrocortisone, sometimes even prednisone. And the reason why prednisone is given is because it's longer half-life than hydrocortisone.
Oh.
Sometimes we need to start increasing hydrocortisone until uh, patients start feeling a little bit better. We discuss as well quality of life is important, and we already know some of the side effects of mitotane. And then you have an adrenal insufficiency, which also has some of the other side effects as well. And I think it's important that you are repleted accordingly based on symptoms as well. And as I discussed earlier, and one of the reasons is because mitotane accelerates the metabolism of hydrocortisone, so you may need more, and it's important that you discuss that with your physician. And again, prednisone has been used. I know that some ACC expert likes to use prednisone because it's
Mhm.
long acting, and you don't have to be given many times during the day.
Mhm.
So now, an adrenal crisis happened when your body is not able to compensate for that stress, whether
Mhm.
it's infection, whether it's surgery. So when you don't have enough of that cortisol hormone uh, to compensate for that stress, that can lead into adrenal crisis. Uh, Usually when I see a patient that may go into adrenal crisis, they very low blood pressure, nausea, vomiting, but they don't feel good at all, and the blood pressure usually goes very low. But we need to prevent that, because adrenal
Mhm.
crisis, if we don't prevent it, can be very dangerous for life. So we need to prevent that. And how do we prevent that? And that's something that you need to discuss with your endocrinologist, is uh, and is that what we call the sick date rules, to prevent any adrenal crisis. So the sick date rules is when, if you, that you can increase the hydrocortisone. For example, you have like a mild cold and you have a low grade fever, maybe you have a little bit of vomiting, but maybe once or twice, unable to keep the pills, but then only one, you can double the dose in that situation. So, and that's important that you need to recognize that. Now, if there is a more of a higher fever, like greater than 102, an infection, an active infection, so in those situations, you may need to uh, triple the dose. So let me just go back. If you have a mild stress in the situation, mild illness, low grade fever, cold, you can double the dose. If you have more of a severe illness, in the sense that you have higher fever, higher than 102, and you also have related to an infection or a GI as well infection, then you can triple the dose. Now, if you're unable to keep the food down and you're vomiting, then at that moment is when we need the emergency shot. So the emergency shot is just an IV, as an injection that you can give yourselves. 100 milligrams of hydrocortisone or methylprednisolone is what it is there, and that can also help as well. And usually we recommend to go to the emergency room.
Right.
And just to summarize, in order to prevent the adrenal crisis, very important, you need to have your bracelets too, or your necklace saying that that you are adrenal insufficiency. You have to put it
Yep.
somewhere, even your cell phone, that you are adrenal insufficiency. Second, you need to recognize and what are the sick day rules, and when you need to either double the dose or triple the dose. That's the second thing. And
Mhm.
third thing is important that you always have with you a emergency shot, which is
Mhm.
actually a hydrocortisone that you can just give yourself. So I think that's very, very important as well.
It is, yeah, definitely. And I know my mom has her little dog tags that she always wears, like with her adrenal insufficiency information, and she has her little emergency pack. So it's important to keep that with you for safety.
It
So
is, because if you're unable, I mean, it's happened, you're unable to keep anything down, you have a viral infection, GI infection, unable to keep anything down, that's when you need to use the injection, and then you need to go to the emergency room just to make sure that everything is okay.
yeah, definitely. But yeah, if definitely talk to your doctors about that if they haven't talked to you about it for sure. So, okay. So, our next question is what are the scanning protocols for sporadic ACC in adults? I know we've had a few people that like don't it's just comes up and they're not necessarily expecting it, which seems to be the nature of ACC. So,
No, that's a good question. And the way we do scans in ACC, for example, if the tumor is resected, uh, we do scans every 3 months for 2 years. That's what we do. That's how we do the scans. Any CT scans, usually what we recommend is the same type of scan. And we do that every 3 months for a total of 2 years. And the reason why we do that is because the recurrence of ACC happens in those 2 years. So that's the reason why it's important to, do the scans. And I know that sometimes, that there's difficulty with insurances, but your doctor always needs to appeal that. And it needs to appeal that this is necessary because it's in every guidelines in regards to adrenocortical cancer. So it's important that, the scans are done every 3 months for the first 2 years. After those 2 years, then you can do the scans every 6 months for a total of 5 years. So that's what we do. And then after that, you can do it every year. I understand that some patients are a little bit more anxious, understandable. I will feel the same. And if we wanted to do it, continue doing it every 6 months, it's okay. I think sometimes it's kind of like it's helping as well. Um, um, to know that we're doing scans a little bit more often. Of course, you need to discuss with your doctors as well, just to make sure that this is, what we need to do. But yes, that's usually what we do for the how we do the scans. And again, the reason why is first why we're doing it every 3 months in the first 2 years, because the recurrence is higher in the first 2 years, about 40% or so, and then after that, is less. But it's still, I mean, that's something that we need to continue watching as well. I don't know if that answered the question, whoever asked that question, but yeah.
Yeah, I think it's come up a few times actually. A few people have asked me that too. So I definitely
I
and
think
then
that's one of the other, if I may add, Amanda, I think one of the other questions as well is that when do we do scans in regards to in pediatric patients, or in regards when patients have also what we call cancer predisposition syndrome, meaning that they have a syndrome that is associated with multiple cancers too. And usually in terms of the ACC, we establish the same for adrenocortical cancer, the same scans with the same interval.
Okay.
Now, in regards to other cancers associated with the cancer predisposition syndrome, either Luframini or Lynch syndrome or MEN1. So we need to follow the guidelines as well. What is recommended for the other cancers associated with the syndrome as well.
That makes sense. Yeah, definitely. So that kind of leads to our next question, actually. Can you talk a little bit about treating pediatric ACC?
Oh, thank you.
Yeah,
Thank you for that. Yeah, I have to say that the NIH is putting a lot of efforts for understand more about the biology of adrenocortical cancer. So just to everyone, I am an adult oncologist. I'm not a pediatric oncologist, but here at the NIH, we're working with our pediatric oncologists, and we see me and the pediatric oncologist, we see the patient together when it's a pediatric ACC. I have to say, not because I work at the NIH, but we communicate all the time. It's a wonderful group to work with. Uh, and the NIH is a great place as well for pediatric, and overall for pediatric cancer. It's an amazing place. And doctors are really caring for pediatric ACC. Now, one thing that I wanted to mention, the pediatric oncology branch got funding through the Moonshot funding to treat pediatric and young adult rare cancers, and ACC is one of them. So I'm very hopeful because it can help us understand more about ACC, not only in adults, but at the same time in pediatrics as well. And I think this is, to me, very hopeful just to be able to see pediatric ACC patients with my colleagues here at the NIH, Dr. John Glott, Dr. Rosie Kaplan. They're phenomenal. And they're also, besides seeing patients, they have an interest to understand more about ACC, how they can help. They're doing research as well, because it's a population that needs help. And I think we need to put all our brains together in order to improve as well the care and follow-up of overall ACC pediatrics and adults. I have to say, just one comment I would like to give is that there is a difference between pediatric ACC and adult ACC. Pediatric ACC, we discussed earlier, majority of them, up to 90% secretes hormone, and we discussed which one is the most common hormone, which is the testosterone androgens. And also something about the pediatric ACC, they respond better to chemotherapy compared to adults. Yes, so they can also tolerate more cycles of chemotherapy compared to adults as well. And I understand sometimes that's worrisome for the parents, but we talk to them, educate, and discuss what is the importance of that. And there is also data out there that tell us how many cycles we need to give for a pediatric ACC and which stage of the, as well of the ACC, whether it's a stage 1, a stage 2, or 3. And I'm happy to discuss the stage if I have a couple of minutes as well, because I think it's important. Sometimes they say, what does that mean stage 1 or what means stage 2? So stage 1 is when the ACC is less than 5 centimeter. That's a stage 1. Stage 2 is when the ACC is greater than 5 centimeters. Stage 2. Stage 3 is when the ACC is greater than 5 centimeters, but also it has some invasion locally, whether they're lymph nodes or some other implants, but it's around the vicinity of the adrenal gland or where the tumor is. And stage 4 is when the ACC is in other parts of the body, lungs, liver, bones. That's where the most common areas. So, yeah.
Okay. So the stages, is the staging the same for pediatrics and adults? Does it work the same?
We do the same staging. Yeah, that's correct.
Okay.
That's
okay.
a good
I was just wondering because the size.
Clinical manifestations is different in terms of pediatrics and adults. But we're trying to understand that as well. And again, the pediatric oncology branch here at the NIH has effort dedicated as well for pediatric ACC and seeing those patients at the clinical center here at the NIH. And me, because the expertise that we built, we see them as a team. So it's a very collaborative team, multidisciplinary. And I think it's important as well for the care and management of ACC to have a multidisciplinary team in order to provide the best guidance and follow-up for our patients.
I can definitely agree with that, having seen my mom have like the multiple doctors working together to take care of her has made all the difference. So definitely helps. So actually, somebody asked a question here. If I was diagnosed at the age of 23, is it adult or pediatric? That's like, is there like a cutoff? Like,
so yes, I mean that's more like a AYA. So is young adult. So that's what it is, young adult, and usually goes from like 18 to 35. So that's usually what it is, AYA. But yes, the pediatric oncology brand, we see pediatric, we see the AYA, the young adults, and then also we see all the adults. So we see all ages. And also, just to mention too, I think it's important is that the reason why we're able to see ACC of all ages is because we do have a natural history study protocol. So the natural history study is a longitudinal study. We wanted to study adrenocortical cancer for a long time,
Mhm.
uh, prospectively, meaning for the future. So we see those patients and we want to collect all the data. And is also for the protocol is in both pediatrics and all ages and adults from 0 to 80 or 90. So we have this protocol because we wanted to understand what is the difference between pediatrics and adults, also understand the genomics as well as the molecular level of all ACCs, because our end goal is to be able to develop better therapies as well. So I think it's important that the way we see all of our ACC patients is because we do have a natural history study that allows to follow the patients long term. We're part of their group of physicians. We give consults to everyone, anywhere in the country, anywhere in the world, pretty much. And then we would provide guidance in terms of treatments, and if needed, we have the surgical expertise here as well for adrenocortical cancer, and we're developing treatment studies too. So that's I think that I have to say that I'm hopeful for what is coming.
Yes. Yes, definitely. Definitely. It's really cool to see like things being studied. Like it's well needed, and we're appreciative to all of you doing the research. So I have to say that as a family member. Um okay, so our next question. Oh, this one's interesting. Have there been studies with hormonal birth control and a correlation with non-genetic ACC?
Yeah, that's a good question. I mean, I have to think a little bit about this. I mean, non-genetic ACC, I assume is more like it's not associated with a cancer predisposition syndrome,
Mm-hmm.
like Lynch or Luframini or MEN1 or familial adenomatous polyposis. That's the other one that is associated with ACC. Becken-Widman is another one that also have a risk to have ACC, not as high as other ones, but in terms of non-genetic, I mean, maybe is just, I assume whoever placed the question may refer to sporadic, meaning that we don't know the cause or not
Mm-hmm.
associated um, with any family predisposition uh, syndromes, cancer syndrome. And, that's a good question. And I have to say that I may have to go back and see if there is any association. Not that I know of, and that's the answer to your question. Not that I
Mm-hmm.
know of. I don't think I have come across to any study or paper that there is an association with birth control and adrenocortical cancer. So there is an association with breast cancer and cervical cancer, but we don't know if there is any association with adrenocortical cancer. Sometimes even, the birth control pills may decrease the risk of ovarian cancer because you don't ovulate as much with
Right.
the birth control, and maybe that decrease that. There is some studies about colon as well, decrease the risk.
Right.
But in terms of increasing the risk of cancer, it has been reported for breasts and for cervical cancer, but haven't seen that has been related to adrenocortical cancer. But that's a good question, and I think it's a good research question, and definitely something that I would like to follow with my patients and go back and see. And one thing about the natural history studies that we ask a very detailed personal and family history, and one of
Mm-hmm.
them is any drugs, any herbs, anything that the patient is taking. We wanted to include it as well.
Yeah, that's a good point. So actually, I didn't. This is really strange. So I didn't know that cervical cancer and breast cancer were associated with ACC. That's
No. With the
no. Oh,
no.
with birth control.
The question was,
Okay.
by taking birth control, there is an association with adrenocortical cancer, and to my
Right.
knowledge, it's not.
There's
So
not.
there is an
Okay.
association with breast cancer and cervical cancer that I know of. I mean, the risk is not that high either, but
Right.
is not to my knowledge there is no association with adrenocortical cancer.
Okay.
Does that
There's okay. That
explain?
yeah. That no.
I
That
just want to make
explains.
sure that is clear, because it's important for me that everything that I say is clear to you. And
Right.
one thing that I have to say is something that I said tonight, and you have a questions, or maybe you would like to revise, just email me. and I will answer any of your questions. I can have a time for you and me to meet if necessary, so that way I can answer your questions, just in case something you didn't understand by this Q&A. And I can understand sometimes we hear there is so much information, and sometimes it's difficult to retain, or maybe
Mhm.
some misunderstandings. So I want to make sure that there is clarity in any of the questions that you ask, and that there is, and just to educate you as much as I can.
Yeah, definitely. Thank you for that, because I misheard you and I was like very confused. So
No,
thank
that's
you for
important.
clarifying.
And also, look, I also have an accent, right? So you need to get used to my accent too. But in any case, yes, please feel free to mail me anytime. I really want us to, make sure that we have time. We can, any questions that you may have, we can answer all of that. So you have my email. Please feel free to reach out anytime.
Definitely. So we are coming up on our last 10 minutes, but do you think you want to do one more question before?
Sure.
Okay. So let's see this one. Um okay. So I'm going to do this one. Are there any studies showing success with Keytruda
Mhm.
and Keytruda lenvima?
Yeah.
Sorry.
That's a good question. And if it's okay, for the 5 minutes, I also want to, because I saw some of the questions earlier when I was
Yeah,
joining.
yeah,
The one
absolutely.
question that I would like to also address tonight is about the difference between ablation and embolization versus surgery. I think that's important. But first, let's discuss about immunotherapy, because
Okay.
immunotherapy we're excited about immunotherapy. Why? Because what immunotherapy is doing is stimulating your immune system in order to attack the cancer cells.
Mhm.
There has been a study, actually, Memorial Sloan Kettering in New York City. Diana Reedy was the one who did a study of pembrolizumab. So the one that is being used is pembrolizumab, because there's many different type of immunotherapy. So you have nivolumab, you have ipilimumab, but the one that has been tested in adrenocortical cancer is pembrolizumab or Keytruda. So Dr. Diana Reedy at an MSK did a study with prospective study, meaning that wanted to understand what is efficacy of immunotherapy and ACC, and in this case pembrolizumab. And she enrolled like about 39 patients or so, and she saw some efficacy,
Oh.
and that's reported. The response rate is in patients, the total response rate, it was about 23%, which is not similar to chemotherapy in a way. It's
Mhm.
not higher that I know of, but it's something that is important to keep in mind as a treatment of adrenocortical cancer. Timing of when to give it, do we give it before EDP, is still unclear. I think usually what we do is that we try to use chemotherapy first, because that's the one that we have the most experience, that's the one that we have the largest information in ACC, and that's the reason why we usually start with EDP. And then other options, will be streptozotocin immunotherapy.
Mhm.
uh, now, in regards to the combination, so they mentioned about Keytruda in combination with lenvatinib. So let's just clarify what is lenvatinib. Lenvatinib uh, is a tyrosine kinase inhibitor. What that means is that it blocks the blood supply going into the tumor. That's what the tyrosine
Oh.
kinase does. There are many of them.
Mhm.
Lenvatinib is one of them, but there are many others of the same family of drugs
Okay.
basically what they do, it blocks the blood supply going into the tumor. That's what lenvatinib does. So there is some data, and that has been on kidney cancer. We don't know in ACC, like if you
Mhm.
combine the two, it seems like it makes immunotherapy more effective. And the reason why is because by giving this drug like Mvat, it can stimulate certain immune systems in the body. And when you give immunotherapy, it's supposed to be synergistic, it's supposed to be more
Right.
effective. We don't know that information in ACC. However, Dr. Muhammad Habra and MD Anderson did review patients that receive immunotherapy in combination with lenvatinib. some patients that they responded. It was a small cohort. It was only 8 patients, so to really determine the full efficacy, I would say. But preliminary information seems that there is some efficacy or some signal, but I think that it's important to do a clinical study in order to really determine whether this medication is effective or not in ACC. I personally use pembrolizumab alone, and the reason why is because there is side effects too associated with the combination treatment, even though immunotherapy is fairly well tolerated, but then the combination, you have other side effects
Right.
too. But something important I want to mention as well, and I usually talk to that about all of my patients. Um, when we discussed earlier that functional ACC secretes hormone, and the most common in adults is cortisol.
Mhm.
So cortisol suppress the immune system. That's excess of cortisol suppress the immune system. And if
Mhm.
you have an ACC that is producing cortisol, you need to control that excess of hormone before starting immunotherapy, because immunotherapy is not going to work with such a suppressed immune system. So it needs
Yeah.
to, so, and that's something that we're trying to educate our patients, and that the excess of cortisol can be controlled with medications. We have ketoconazole, methylapone, so we have different drugs that help control the excess of hormone, but it's important that we control that excess of hormones. That way we can give immunotherapy for those patients that the tumor produce cortisol only, because it's a cortisol suppress the immune system. So we give immunotherapy, we may not have the same efficacy. So I think it's important that we control the excess of cortisol before we can give immunotherapy.
That totally makes sense.
Yeah. So, and the other thing that when I was looking earlier at the questions was about ablation, embolization versus surgery. And I think it's a
Yes.
good question. And I actually like that question too,
Okay.
because liver directed therapy, so meaning therapy only to the liver, is an option for patients with adrenocortical cancer. And sometimes it's important to control the growth of the tumor in the liver to
Mhm.
then give other systemic therapies. So in terms of this type of liver-directed therapy, we have ablation and we have embolization. For ablation, so there are two different types, more or less. We have microwave radiofrequency ablation and microwave ablation. So basically what it is that when there is a tumor in the liver that we wanted to ablate, so we do it based on with the imaging. So we have an imaging and we localize the tumor. There is a needle that goes through the skin, and then it localizes the tumor. And then basically with the radio frequency with the microwaves, what it's doing is trying to produce heat in order to kill the tumor. That's what it is.
Oh.
Ablation is good for those tumors that are less than 4 centimeters in size, or more or less an inch and a half. So that's when ablation is good. When the tumor is about less than 1 inch and a half, ablation can be considered. And again, that's localized, is through the skin, and localize the tumor in the liver, then through the skin, localize the tumor, then with the either radio frequency or microwave produce heat that kill the tumor cells. Now, embolization is different. Embolization is going into the hepatic artery to block the blood supply going into the tumor. I have to say, liver is a fascinating organ, because the tumor gets his food from the hepatic artery, from the artery of the liver.
Right.
So what embolization does is that it uses a small catheter, is very flexible, and then from around the groin area, so they localize the artery there, and then it goes all the way to the hepatic artery, and it can deliver a treatment in three different ways. One is what we call bland embolization, so meaning that there are some particles that is delivered in order to cut the oxygen going into the tumor. So
Mhm.
we call that bland embolization. The second one is chemoembolization. So you give chemo,
Hmm.
going the same techniques, you just deliver chemo.
Right.
And the third one is radioembolization, meaning that you give radiation and through the catheter. And that's usually what we know as the E390 or Y90. That's what it is, the different ones. We don't know really what is best in terms of the three of them. For ACC, we usually here use chemoembolization. Doesn't mean that it's better, but that's what we do for patients with ACC. And it's different. So we discussed the difference between chemo and ablation, embolization, and then surgery. Surgery, they open, they just
Yep.
scalpel
The,
to cut the tumor, right?
yep.
So ablation is a needle that produces heat and through the skin, and embolization is going through the hepatic artery and deliver different substance, different particles in three different waves. So I think that's important.
That is really interesting. I'm really glad you answered that.
I like that question because I think it's important, when somebody asks me about that, I think it's important to recognize and it's a treatment that can be, discussed. And that's the reason why I like to discuss my ACC patients with a team, just to make sure that we provide the best guidance. And interventional radiologist is also one of them too.
Excellent. Okay. Very cool. So, since we're getting close to the end, I really want you to talk about the studies you're doing at NIH, what you do, just kind of have the floor and go for it.
Oh, thank you so much. Well, first, as I discussed earlier, thank you for having me today and for listening. And I'm happy to answer any questions. So, and I believe, Amanda, I think you did post the email earlier today. But
I
yes, thank
did.
you so much.
There
There
we
is
go.
my email. So, you have any questions, if you want a second opinion consultation, we do it. And actually, what we do at the NIH is free of cost. So the reason why is because every patient that we see at the NIH needs to be enrolled on a protocol. It's either a natural history study or it is a treatment study, clinical trial study. As I say earlier, we have a natural history study that allows me to follow patients over time. It's not a treatment study, so we don't necessarily give treatments, but it's helped me to understand more about patients with ACC over time. And this protocol also allows me to talk to physicians to make sure that, being a part of your group of doctors. That's a natural history study. And then we have treatment studies. We're working also on treatment studies for ACC. The natural history study also allows us to do surgery here. I think we do have excellent surgeons here who have expertise in adrenocortical cancer. So they're very good and they understand. And one thing that is important about ACC is that it's important to have that is done by a surgeon who knows ACC. And the reason why is because by having a good surgeon, the risk of recurrence is less because they know what to do. They can explore lymph nodes. So this is important in a surgery for ACC. So it's important that you have a good surgeon with an expertise in adrenocortical cancer, a surgical oncologist, or surgeon who has expertise. So that's very important. And I think there is background interference.
Is anyone else having background interference in the comments? If you just want to post,
Yeah.
But you
Yeah.
can keep going. We'll
Okay.
keep an eye on that.
And by doing surgeries, what we do is that we ask the patient, can we take a small piece of your tumor to do research? And again, everything that we do at the NIH is optional. Yeah, so that's something that I want to clarify. Everything that we do is optional here. If you just want a consultation and that's it, that's okay too. We can do that. If you want to be part of the study, you can also do that as well. So I think it's important that, the patients that come here have surgery, ask the patient, can we take a small piece of the tumor? So that way, as I say earlier, we can do it for research. Something that we are doing here at the NIH, I think is exciting, is that we're trying to grow organoids of those tumor. So what is organoids? Organoids is we take the tumor from the patient, we put it in the media, and we grow, we grow those cells. So it's kind of like mini organs in a way. So it's kind of like we grow those cells and we try to keep those cells as long as we can alive and keep them, growing, because the goal is to be able to test different drugs to those organoids. And I have to say, I'm very, very excited about this because I don't think that has been done for ACC. I mean, the
I don't
scientists
think it
here,
has.
I really
Yeah.
put a lot of effort, and the fact that we're able to do these type of organoids to be able to test so many drugs,
Hmm.
that we have here at the NIH, I think it'll be important, and then hopefully we can have a good treatment option, because as you all know, what we lack in ACC is that we don't have effective therapies. We don't have tumors that help decrease the tumor growth. And we're working really hard here to be able to develop models for ACC. I think one of the reasons is because we don't have models for ACC, and
Hmm.
to be able to test different drugs, or to
Right.
be able to understand the biology of adrenocortical cancer. But we are really working hard, and hope, it has been successful, to doing those organoids, and we're moving to the phase that we wanted to do drug tests, and that's I think that would be important to develop therapies for ACC. And I'm excited about that. And every protocol, every patient that we see here at the NIH is free of cost. So you want to be a part of the study, or if you want to consult, is we don't charge, and also we can also do scans or blood work if necessary. And I think this is just a blessing to be here and be able to do that and help, those patients with ACC, because we know that our patients with ACC, they need all the help they can, right? So because we know that sometimes dealing with insurance is so problematic, and sometimes, like things that it may be easy for another cancer to get approved is very difficult for a patient with ACC. So I just feel like we have this opportunity. We want to help with the Red Tumor Initiative in the pediatric oncology branch. We're putting a lot of effort in ACC. It has been a work in progress, and it has been a lot of work, but I have to say that it wouldn't be possible with the patients that dedicate, come here and talk to me. You are the stars here. I mean, you are the motivation what we do in this. And I think that that's one of the main research that I do at the NIH. We're trying to understand more the genomics, the molecular level, understand too, because it seems that some patients with ACC may respond better to one treatment than others. It's very different. And why is that? I think we wanted to understand that by studying the genes, all the molecular level of ACC, and also be able to develop better therapies. And we're really working hard with collaborating with other institutions outside of the NIH. So because I think the only way that we can advance is by working together, not just the physicians or the scientists, but also patients. I mean, you are the most important part of the question, like you are the inspiration what we do in this. And I think that we should definitely continue forward in medicine with patients. We have to have patients into accounts in everything that we do, and show the patients what we're doing too, because that way, if you know what I'm doing, then you feel like there's somebody doing something, and I think that's important as well.
It is. It is. It really helps to have someone like you working on this for us. Like, you
Mhm.
know. So, I think, did you have anything else you wanted to say?
Oh, I just happy to be here with you all. If you have any questions, um, here's my email. If you want to see me again, just happy to see you, and discuss any questions that you may have. And it's important as well that I always tell my patients too, it is a rare cancer, and if and in between physicians we may have different approach too, but I think it's important that you see as many opinions as you can, so that way whatever decision you make, you're comfortable with the decision, and I will support any decision you make. We're a team here, and remember, we are a team. This is important. The way I treat my patients, I want to believe that we are a team working together, and that you have knowledge is power, that's for sure. So you
Yeah.
need to ask all the questions. Not questions is simple or stupid. You have to ask all questions. We're here to answer all of your questions. Write your questions so that way you know what to ask the doctor. Sometimes when you go to the doctor's office, you wanted to ask A, B, C, and D, and then you forget, right? So it's important that you write your questions so that way.
Definitely.
And sometimes even with mitotine, sometimes it can get a little bit forgetfulness. So it's that's easier. Maybe you can bring somebody with you to be able to also record, or when you ask questions to the physician. I think that's important. And what I'm saying, we are all a team together, and I'm really I'm really hopeful right now with what has been done and with further collaborations, and we're here for you. You're not alone on this. I know it can be very hard, but you're not alone here. You is this Facebook, this is amazing. You have a lot of support, but if there is any questions, where you can find me.
Thank you so much for doing this interview with me tonight. I so appreciate it. I'm gonna try to put up some more links to Dr. Del Rivero's like NIH page and a couple other things. So keep an eye out on my link tree and everything for everything. And thank you again. And everyone have a great night.
Thank
Take
you so
care.
much. See you soon. Bye.
Bye.